Yeah, thank you. So good evening, all of you, for this joining this evening virtual meeting of Api-Icp postgraduate training program. So we have with us Dr. Rajkumar, Professor of Medicine from Salem Medical College, joining as a faculty of Medicine Department. And we have a specialist faculty from the Department of Cardiology, Dr. Pachayappan, Associate Professor of Cardiology, is going to join soon. And we have Dr. Shushmita, the postgraduate from Salem Medical College, is going to present the case on the cardiovascular system, more of valvular heart disease. Over to Rajkumar sir and Shushmita to take over further proceedings. Let him join, and he can join the discussion also. Thank you.
Thank you, sir. Shushmita, can we start?
Start the presentation.
Good evening to everyone. I am Dr. Shushmita from GMKMC at Salem, final year medicine postgraduate. Today I am here to present a case of cardiovascular system. Shall I proceed, sir? Shall I start, sir?
Yeah. Yeah, please.
Mr. Krishnamurthy. Yes, sir. Yes, sir. Mr. Krishnamurthy, 42 years old male, coming from Atyampatti, Salem, farmer by occupation, belonging to lower socioeconomic status, has come with chief complaints of breathlessness for the past 6 months, palpitations for the past 2 months, and chest pain for the past 2 months. History of presenting illness. Patient was apparently all right performing his daily activities before 6 months. Then he developed breathlessness since 6 months, insidious in onset, progressive in nature, aggravated for the past 2 months. Initially, he noted breathlessness on exertion, walking 3 flights of stairs or 500 meters on the ground level, then gradually progressed to current state where the patient develops breathlessness on walking 1 flight of stairs or 50 meters inside the home, which was progressed to NIHA class 2 and NIHA class 3, which was aggravated by exertion and work, relieved by taking rest, developed awakening from sleep 2 hours after the onset, which was relieved on sitting and leaning forward, taking deep breaths for the past 2 months, which was associated with cough, not associated with orthopnea. History of presenting illness for the past 2 months, which was present at rest, sudden in onset, regular, increased on exertion, and decreased in intensity while taking rest. No post-palpitational diuresis or syncope. History of presenting illness. History of chest pain for the past 2 months. Gradual onset, pricking type of pain, left-sided, not radiating, aggravated by exertion, and relieved by rest. History of easy fatigability present. No history of giddiness. No history of loss of consciousness. No history of coughing up of blood. No history of hoarseness of voice or voice change. No history of difficulty in swallowing. No history of decreased urine output. No history of swelling of legs. No history of abdominal distension. No history of right hypochondrial pain. No history of fever and sore throat. No history of joint pain and swelling. No history of involuntary movements. No history of any skin manifestations like rashes and nodules. No history of recurrent respiratory tract infection. Past history.
Susmita, go back to the first slide. From the history, what do you want to tell us? Breathlessness for past 6 months, palpitation for 2 months, and one more symptom is?
Chest pain, sir.
Chest pain. Okay. Yes. Why do you use NIHA classification?
Sir, depending upon the symptoms, the patient may have cardiovascular disease, so NIHA class is used, sir.
Okay.
Breathlessness, chest pain, palpitation, more in favor of cardiovascular disease, sir.
Why respiratory system you won't get any breathlessness?
Because there is no cough with expectoration or any fever history, sir.
Okay. What is specific for cardiac illness? What do you think in terms of cardiac, apart from cough?
So palpitation, sir.
Palpitation. Can you get palpitation in the respiratory system?
No, sir.
No.
No, sir.
What is low atrial fibrillation?
Sir,
Low atrial fibrillation. Can you get atrial fibrillation in pneumonia? Can you get atrial fibrillation in pneumonia?
yes, sir.
Okay. Then what are the causes of palpitation in 42 years patient?
It may be due to tachyarrhythmias, maybe due to valvular heart disease, maybe due to cardiomyopathy.
Okay, young patient, you think MVP?
Yes,
Okay.
sir. Mitral valve collapse.
Okay. Is there any PND in your case?
Yes, sir. PND is there, sir.
Is it specific for cardiovascular system?
Yes, sir. It's more specific for cardiovascular system. Indicates the early cardiac failure, sir.
Early cardiac failure.
Susmita, is it early cardiac failure, PND? Define
Early-
PND. Define
patient
PND.
develops dyspnea after 2 hours of sleeping, sir. Earliest manifestations of congestive cardiac failures.
Which class do you expect a PND? Naika, in which class do you expect PND?
NIHA class 3, sir.
Orthopnea?
NIHA class 4, sir.
Okay.
So 3 is it early? There are 4 stages. It's 3.
Yes, sir.
How can you call it as a yearly? Define anginal chest pain.
Anginal chest pain is central and diffuse, which was increased on exertion and relieved by taking rest or any nitrate, sir.
Chest pain. What are the various type of typical angina?
Chest pain centrally located and diffuse, squeezing type of pain, increased on exertion and relieved by taking rest.
Mute, right? Mute. Cardiac chest pain, anginal chest pain, you can get it from jaw to umbilicus. It may
Yes, sir.
radiate
Radiating
from
to
jaw to
radiate.
okay. Dryness of mouth also you can get it. There are a lot of angina variants you can get it. Okay. Occurs
Okay,
on
sir.
exertion, relieved by taking rest. Okay.
Okay, sir.
It may be diffuse or central compressing in nature,
Okay, sir.
or you can get burning sensation over the chest. Okay.
Okay, sir.
And dryness of mouth also, various type of angina you can get it. The chest pain you can get it from the jaw to up to umbilicus. Any type of pain, you have to rule out cardiac chest pain. Okay.
Okay, sir.
Do you get cough in cardiac problems?
Yes, sir.
Which condition you will get cough?
In left heart failure, we have cough, sir.
But you are told cough will not be there in cardiovascular system.
Yes, sir. It will be there, sir. In left heart failure, there will be cough, sir.
Okay. Palpitation, do you get palpitation in respiratory condition alone?
Yes, sir. There is
Palpitation, you can get it in any condition, any systemic illness, you can get palpitation.
okay, sir.
Okay.
Okay, sir.
Any condition, you can get it palpitation. Sinus tachycardia, any tachyarrhythmias, you can
Yes, sir.
get
In
it.
pulmonary, acute pulmonary embolism, we can get it. Sinus tachycardia, palpitations.
Okay. Acute pulmonary embolism, history-wise, how will you suspect?
Patient had sudden onset of chest pain. We can suspect pulmonary embolism. So,
Sudden onset of chest pain. Maybe
sudden onset of
acute
chest pain,
syndrome.
sudden onset of chest pain, sudden onset of breathlessness. We can suspect pulmonary embolism. So.
Okay. Following surgery or prolonged immobilization, all background history also very important.
Okay, sir.
Okay. Always treatable condition is very important. You have to suspect.
Okay.
As a postgraduate students, you have to suspect acute conditions, treatable conditions. Okay.
Okay, sir. Okay, sir.
You have to rule out any acute coronary syndrome as well as acute pulmonary embolism, right heart failure or left heart failure, whatever it is. Okay.
Okay, sir.
You have to suspect early and treat accordingly. Okay.
Okay, sir.
Define hemoptysis.
Hemoptysis is defined as coughing up of blood. It may be due to pulmonary conditions. In cardiac condition, mitral stenosis, pulmonary apoplexy due to increased LA pressure.
What vital stenosis?
Yes, sir.
Okay.
In long-standing mitral stenosis, there will be pulmonary infarction leading to hemoptysis, or increased LA pressure causing a bronchial wall rupture leading to hemoptysis. Pulmonary congestion may lead to hemoptysis, and pulmonary edema may lead to pink frothy sputum.
Pulmonary, that's acute pulmonary edema. You will get not hemoptysis, pink frothy sputum. Okay. Pulmonary infarction following acute pulmonary embolism. You can get severe chest pain along with hemoptysis.
Okay, sir.
Okay.
Okay, sir.
Yeah. Yes, sir. Pachepan sir, you can proceed.
Hello, sir. Yeah. Hello, sir.
நல்லா இருக்கீங்களா? எங்க இவரை காணா? என் ஃப்ரெண்ட் வருவாருன்னு பார்த்தேன் உங்க அச்சோடி.
HOD, sir, he was engaged somewhere, sir. So he asked me to.
கேட்டேன்னு சொல்லுங்க. சரவணன் லைன்ல இருக்கீங்களா? ராஜ்குமார் விஸ்வநாதன்.
Yes, yes, sir.
நல்லா இருக்கீங்களா?
நல்லா இருக்கு, நல்லா இருக்கு. Fine.
Yeah. Susmita, proceed.
Yes.
Doctor, proceed, doctor. Okay.
Sir, from starting or should I start with past history?
2 months. No, I gone through the history. The slide. Okay. You can proceed. 2 months history of palpitation, slowly progressive. Okay.
Yes, yes, sir. Coming to the past history, there is no history of similar illness in the past. History of fever with sore throat and large joint pain when he was 12 years old, which got relieved by medications. He was asked to take medications for a long time, but he lost to follow up. No history of recurrent respiratory tract infection in childhood. No history of any drug abuse, previous surgery or dental procedures. No history of diabetes mellitus, hypertension, coronary artery disease, thyroid disease, tuberculosis, seizure disorder, chronic lung disease, chronic kidney disease, or COVID-19 infection. Personal history: smoker for 15 years, smokes 5 to 6 cigarettes per day, consumes alcohol occasionally, no history of any high-risk behavior, taking mixed diet, history of disturbed sleep for the past 2 months, probably due to PND, normal appetite, normal bowel and bladder habits. Family history: there is no history of any cardiac disease in family members, no history of cardiac-related death in family members.
What type of cardiac illness you want to expect? Familial.
The cardiomyopathy, it's a autosomal dominant, sir. Hypertrophic cardiomyopathy may be familial, sir.
Okay.
Doctor, all the cardiomyopathies can run in families. Not only HCM, even DCM, familial DCM can occur, and restrictive cardiomyopathy can also run in family. All the 3 types can run in family. What are the other ailments that run in family apart from cardiomyopathy?
Long QT syndrome.
Good.
Brugada, sir.
Brugada, okay.
Brugada long QT syndrome.
Can your case runs in family, rheumatic heart disease?
Yes, sir. 15% there is chance of rheumatic heart disease in family members.
What are the congenital heart disease likely to run in family? Have you heard about familial ASDs? ASDs can run in family. Rarely TOF can run in family.
Okay, sir.
Any history suggestive of premature ASCVD? What is premature ASCVD? Premature atherosclerotic cardiovascular disease.
Yes, sir.
Any father or mother, okay? For the
Okay,
father before 55 years, mother before 65 years, any family history of ASCVD, like any acute coronary syndrome, sudden cardiac death, or cardiovascular CVA, okay, all the things you have to ask. Okay.
Okay, sir.
As a clinician in future, after finishing your MD, it's very important.
Okay, sir.
Family history of sudden cardiac death or family history of ASCVD, especially acute coronary syndrome, You have to get the history. Because if the father dies due to ACVD, sudden cardiac death or acute coronary syndrome, at the age of 50, children, chances for getting the children is 25 to 50%. Okay, both the parents means 100%.
Okay, sir.
Okay, a lot of
Okay.
chances are there. So
Okay,
you
sir.
have to
Doctor,
take a history.
Yes, sir.
Doctor, tell one condition which the sir narrated, no, with family
Yes, sir.
history of sudden cardiac death, with anginal symptoms,
Yes, sir.
which disease mimics like that? The runs in family mimics like CAD, but it's not CAD. What is that? Runs in family mimics CAD. ECG shows angina-like pattern. Patient have angina, risk of sudden death, but it's not CAD. Hypertrophic
Hypertrophic cardio.
Hypertrophic obstructive cardiomyopathy.
Okay, sir.
Okay, even
Okay.
MVP with MR.
Yes, sir.
Okay, arrhythmia can occur. MVP, that's not, it's rare, but obstructive cardiomyopathy. Okay, Kalanidhi
Okay, sir.
Maran died due to obstructive cardiomyopathy.
Okay, sir.
You should know. Okay,
Okay, sir.
it's like a anginal chest pain, but the obstruction causing the aortic obstruction, it causes the death. Okay, sudden death, you can get it.
Okay, sir.
Yeah.
Doctor, in your history, patient had a rheumatic fever. No.
Yes, sir.
What about the treatment for that? What was the treatment given for that?
He took NSAIDs, sir. NSAIDs for that pain and fever. Then the symptoms settled. Then he asked to follow up for longer period, but the patient lost to. He asked to take medications for a long time, but the patient lost to follow up, sir.
What medicine they might have prescribed actually?
NSAIDs, sir.
Probably.
NSAIDs or aspirin.
No. What medicine they could have prescribed to take for a longer time for a rheumatic fever?
The penicillin, sir. As a primary profile, as a secondary prophylaxis, they would have prescribed penicillin, sir.
What is the role of penicillin in preventing acute rheumatic fever?
So there is a chance of from group A beta hemolytic streptococci causes rheumatic fever in 3% of population, sir. So we have to give primary prevention to in preventing rheumatic fever. That is IM benzathine penicillin 1.2 million units. Single dose is
I am
enough.
not asking about. No, not about that dosage alone.
Yes, sir.
What is the benefit of penicillin in preventing rheumatic fever? Patient is having sore throat, streptococcal infection. How much penicillin will protect against onset of rheumatic fever from sore throat? It is about 60 to 80%.
Okay, sir.
Okay, it's not 100%, but it will prevent 60 to 80% of the occurrence of acute rheumatic fever in patients having sore throat.
Okay, sir.
Define Jones criteria to diagnose rheumatic fever.
Yes, sir. We are following now is modified Jones criteria, which was revised in 2015. According to modified Jones criteria, the population is divided into low risk and high risk based on the incidence of acute rheumatic fever in school-going children is less than 2 per 1 lakh population, and prevalence of rheumatic heart disease in population is less than 1 per 1,000 population. It is low risk, sir. If it is more than 2 or more than 1, it is high risk, sir. Subclinical carditis also are included in minor and major criteria. Before 2015, there is only polyarthritis, but in revised criteria, there is a polyarthralgia and monoarthritis in low risk to high risk population. Then in minor criteria, monoarthralgia added to the low to high risk population. Then fever is 38.5 degrees Celsius in high risk population, 38 degrees Celsius in low risk population, sir. Then ESR 60 millimeter per hour in high risk population, in low risk population 30 millimeter per hour in high risk population, sir.
What is the most common presentation rheumatic fever?
In rheumatic fever, most common presentation is arthritis, sir.
Most specific?
60% arthritis, sir.
Most specific?
Most specific for rheumatic fever is also arthritis, sir.
Carditis.
Carditis.
Carditis. Pancarditis.
Yes, sir. Pancarditis. Pericarditis. Okay, sir.
What do you mean by pericarditis, doctor?
Involvement of endocardium, myocardium, and pericardium, sir. In endocardium, there will be involvement of mitral and aortic valve. In myocardium, there will be cardiomyopathy, heart failure. In pericarditis, there will be pericardial effusion, sir.
Rather, we can say as it's a fibrinous pericarditis. Pericardium is fibrinous pericarditis. Myocardium is interstitial myocarditis.
Okay, sir.
And endocardium is verrucous endocarditis.
Okay, sir.
Okay, you can
Pathological feature.
you can
To
present
the,
this in a
to the
better
point
way.
specific, okay.
Yes.
Verrucous endocarditis. You forgotten, you have studied in pathology.
Okay, sir.
Which is responsible for caricum murmur?
Caricum murmur is acute rheumatic valvulitis in AR, acute AR, sir. Acute AR, sir.
Due to
Acute air.
Yes, sir.
Air.
No, it's not caricum, doctor. It's MDM.
MD.
Yes, sir.
MDM murmur. Valvulitis of MDM murmur is caricum. What you are saying is polycystic murmur.
Yes. Polycystic murmur in aortic regurgitation.
Aortic sclerosis or regurgitation.
What is specific about the rheumatoid arthritis?
How will you differentiate rheumatic arthritis and rheumatoid arthritis?
So in a rheumatic arthritis, there will be asymmetric migratory large joint involvement, sir. In rheumatoid arthritis, there will be small joint and a large joint involvement. In rheumatoid arthritis, there will be RA factor positivity. In
Symmetrical polyarthritis or monoartic arthritis both can occur in rheumatoid arthritis. Okay,
sir.
symmetrical mostly.
Okay, sir.
But sometimes monoarticular arthritis also can occur in rheumatoid arthritis. But here, migrating polyarthritis. Today, right side knee joint, next day, left side hip joint, like that, migrating. And they cannot walk at all. The patient, the typical history, the parents may carry the patient. Okay.
Okay, sir.
Severe pain, unbearable pain. But rheumatoid arthritis is not like that. Typical history, 5 to 15 years.
Okay, sir.
Okay. And subsided on its own or some treatment.
Okay, sir.
If arthritis persists for more than 3 weeks, you suspect some other arthritis. It's not rheumatic fever.
Yes, sir.
Okay.
Rheumatoid usually 6 weeks, usually you will tell, no. Here,
yes,
more than 3 weeks. Usually it will settle within 3 weeks. Rheumatic arthritis.
Okay, sir. Okay, sir.
Erythema, nodo, some other things, all the things. But the modified Jones criteria, you have enumerated rightly. Yeah. Yes, sir, you can proceed, sir.
Proceed.
Okay, sir. Okay, sir. Summary. 42-year-old male patient with no known comorbidities with significant past history of large joint pain suggestive of rheumatic fever, presented with breathlessness for the past 6 months, progressed from NIHA class 2 to NIHA class 3, associated with paroxysmal nocturnal dyspnea and cough, history of regular palpitations and chest pain for the past 2 months. Based on the history, the probable system involved is cardiovascular system, most likely to be acquired valvular heart disease, probably rheumatic in etiology, causing left-sided disease, probably regurgitant lesion involving either mitral more than aortic or both.
What are the causes of acute AR?
Acute AR, it may be due to rheumatic fever, sir. Infective endocarditis.
That is rheumatic carditis. Usually 5 to 15 years, acute AR. And important thing is IE, infective endocarditis, rightly you said. How will you differentiate between these two?
By clinical manifestation, we can differentiate, sir. In rheumatic fever, the patient may have arthritis.
Doctor, sorry to interrupt.
Yes, sir.
Rather, what are the similarities between similarities of presentation of infective endocarditis and rheumatic fever? What are the differences of infective endocarditis and the rheumatic fever? What are the similarities in presentation? What are the differences? How will it differentiate?
So differences in clinical manifestations, sir.
No, not
like
first tell about the similarities. How do they
similarities.
present? Rheumatic,
Patient may have fever. In both, the patient may present as fever.
Both will have arthritis.
Okay, sir.
Both may have arthritis.
Okay, sir.
Okay.
Okay, sir.
And features of carditis like palpitations, both may have.
Okay, sir.
Both may have. How will it differentiate? What are the things? Both may have skin manifestations.
Yes, sir.
Okay.
Skin manifestations like erythema nodosum and subcutaneous nodules and erythema marginatum is there in rheumatic fever. So in infective endocarditis, there will be mucosal petechiae, Janway lesions and splinter hemorrhages. Osseous node will be there, sir.
How will you differentiate?
The subcutaneous nodules in a rheumatic fever is painless, which is freely mobile, but the osseous node is present in the pulp of the finger, which is extremely painful, sir.
Okay.
Then skin lesions like that erythema marginatum is a pink non-pruritic, mostly in the upper trunk and limbs, but that Janway lesions in the palms and soles, mostly in the palms and soles, sir, which is also not painful, sir.
They are all rare. They are all rare features. Tell some common features in infective endocarditis. Patient will have clubbing.
Clubbing, sir.
Clubbing.
Clubbing.
What is changing murmur?
Sir?
What is changing murmur?
Changing murmur in infective endocarditis, sir.
Any other condition?
In a
MEP also will get the click on and off, doctor. MEP is also, there are few conditions called evanescent conditions. You can, one day will see, one day or the same day also, one person may see and another person may not see that. What are those conditions? The clicks, especially MEP.
MVP, systolic click. So.
Extins click and all.
Extins, okay, sir.
And the pericardial.
What type of murmur you will get in left atrial myxoma?
In left atrial myxoma, there is late diastolic murmur, sir. Late diastolic murmur, sir. In atrial myxoma, and also MDM, mid diastolic murmur, sir. In valvular thrombus and atrial myxoma, there will be mid diastolic murmur, sir.
Will it change its position or not? Sir asked about changing murmurs, no?
Yes, sir. Yes, sir.
If you change the position, it will. If there is an occlusion, you will get the murmur. If you don't get the occlusion by changing your position, you won't get the murmur.
Okay, sir.
Always you have to keep it in mind. Okay.
Okay, sir.
The important condition, left atrial myxoma, you have to rule out. Okay.
Okay, sir.
Infective endocarditis, you have to keep it in mind.
Okay,
And
sir.
especially, SAR has pointed out obstructive lesion, obstructive cardiomyopathy causing aortic stenosis, sudden death can occur. These are all the things you have to keep it in mind.
Okay,
Okay.
sir. Okay, sir.
Sometimes MI mimics you will be getting. Okay. Like typical pattern of myocardial infarction. Okay. Myocardial infarction, obstructive cardiomyopathy, something you can get it. And pericarditis, severe pericarditis. When I did MD along with your HOD, okay, Kannan, we have, that is amoebic abscess, liver abscess ruptured into the pleura, it ruptures into the pericardium, it producing typical MI. Okay, we have not, luckily we have not thrombolized. If you thrombolize, patient will pop up. Okay, And another important thing is dissection of aorta, causing
Yes, sir.
aortic regurgitation.
Okay.
These all things you have to rule out before giving thrombolysis. Okay, various ECG manifestation and clinical features, it will clinch the diagnosis. Okay, when to give thrombolysis, when to not to give thrombolysis also you should know.
Okay,
This is
sir.
all the emergency situation as a emergency physician, you should know. Okay.
Okay, sir. Okay, sir.
So common condition, you have to, especially what to give, we should know. At the same time, what not to give, you should know. That's very important. Okay,
Okay.
you cannot kill the patient with by giving some injections. Okay,
Okay.
all
Okay,
the
sir.
things as a physician, complete physician, you should know. Yeah, yeah, doing very well. You can proceed, Susmita. All the best.
Thank you,
Achepal sir,
Doctor,
thank you so much. Vishwanathan
patient
sir,
is,
bye. Thank you, sir.
if patient is having splenomegaly, it is acute rheumatic fever or infected endocarditis?
Infective endocarditis, sir.
Another cause of acute AR is aortic dissection. Sir
Okay,
asked
sir.
about
Okay, sir.
you told about infective endocarditis and what you told? Acute AR, acute rheumatic fever and infective endocarditis. Other causes is aortic dissection.
Okay,
And one
sir.
rare cause is chest trauma. The one valve which get
Blunt-
damaged,
Blunt trauma.
the one valve which get damaged during blunt trauma is only
Aortic.
aortic. Okay. Okay, proceed. So why are you not thinking about congenital heart disease?
So the patient not giving history about the cyanotic spells or any recurrent respiratory tract infections. There is no any squatting episode, sir. So
Okay, you are ruling out shunt lesions and cyanotic
Yes, sir.
heart disease. Why can't it be any other any other congenital heart disease? What congenital heart disease will present only with palpitation and breathlessness? You have to rule out Epstein's.
okay, sir.
Epstein's anomaly will present only with palpitation, sometimes with breathlessness, but
Okay,
not
sir.
with PND, because not with signs of left heart failure. As you
Failure.
mentioned about PND and all, it's unlikely.
Okay, sir.
Can it be acquired valvular heart disease? Palpitation with the left heart failure. Which acquired valvular heart disease will present at this age, 42 years?
Sir, ASD, sir.
Valvular heart disease. That have bimodal
Valvular.
presence.
Yes, sir.
Which
Bicuspid
Very
aortic valve, sir.
Good. What are the points against that? Why are you ruling out you are not thinking about bicuspid aortic valve? Which are in favor of rheumatic?
Due to in bicuspid aortic valve, there is aortic stenosis. In aortic stenosis, there will be a fixed cardiac output which manifests as syncope. But the patient is not complaining about any syncope, sir.
Okay. Can you get palpitation?
Yes, sir. Palpitation also there, but it is irregular and only on exertion it will be present, sir.
Can present as both, but predominantly stenosis. Okay. They can have
Okay,
also regurgitation.
Okay, sir.
Suppose a patient is not giving history of rheumatic fever,
Yes, sir.
can still it be a rheumatic fever?
Yes, sir.
Or
50% of patient does not remember the rheumatic fever history, sir.
Okay. Okay, Dr.
So coming to the general examination, patient is conscious, oriented, afebrile, moderately built and moderately nourished, no pallor, no icterus, no cyanosis, no clubbing, no lymphadenopathy, and no pedal edema, sir. Anthropometry, weight 62 kgs, height 164 centimeters, BMI is 23.8, no morphonoid body habitus, upper segment is 76, lower segment is 88 centimeters, upper segment, lower segment ratio is 0.8, which is normal. Arm span is 166 centimeter, arm span to height ratio is 1.01.
Is it important anthropometry in your case?
Yes, sir.
Relevant? How?
Yes, sir. If the patient, if the upper segment, lower segment ratio, upper segment is lesser than, lower segment is greater than upper segment, we have to suspect Marfan's, Klinefelter's, and homocystinuria.
What way it's going to help in your case?
Sir, any Marfan syndrome we have to rule out, sir. In any valvular heart disease, we have to rule out Marfan, sir.
What are the cardiovascular manifestations of Marfan's?
Aortic root dilatation and MVP may present.
Only aortic root dilatation. Huh?
Mitral valve prolapse, sir.
Mitral valve prolapse. Then what happens to aortic valve if there is root dilatation?
Yes, sir.
You will get AR.
AR, sir.
Very well, it will very well mimic like your case. If you are, I think you are presenting about AR and MR.
Yes, sir.
Okay. So it's very well mimic. It's very much important in your case.
Okay, sir.
Anthropopathy. Okay, proceed.
There is no external markers of congenital heart disease like hypertelorism, Mongolian slant, shield-like chest, web neck, elfin faces, limb anomalies. No external markers of infective endocarditis like clubbing, splinter hemorrhages, mucosal petechiae, Janvi lesion, Osler's node, Roth spots. No external markers of acute rheumatic fever like erythema marginatum, subcutaneous nodules, fever. No external markers of atherosclerosis like earlobe trees and xanthelasma, sir.
Doctor, in the first line, no external markers of congenital heart disease.
Yes, sir.
You are telling about hypertelorism, Mongolism, shield chest. These are all not relevant in your case. What is the important thing you have to look for in the general examination? If you suspect Marfan's.
Marfan's individuals will be thin and tall with a hyperextensibility of joint. There is dolichocephalus, high arched palate, and chest deformities are there, sir. Pectus carinatum, pectus carinatum, and pectus excavatum.
Especially kyphoscoliosis.
Kyphoscoliosis.
They will have kyphosis. Okay. That you have to mention. Okay. No. Proceed.
So, vitals examination, pulse 104 per minute, regular in rhythm, large volume pulse, collapsing in character, no vessel wall thickening, no radio-radial delay or radio-femoral delay. All peripheral pulses felt equal on both sides in all accessible sites. Blood pressure, right upper limb 110/50 millimeter of mercury, left upper limb 110/50 millimeter of mercury, right lower limb systolic BP is 170 millimeter of mercury, left lower limb systolic BP is 170 millimeter of mercury. There is difference in popliteal cuff pressure and brachial cuff pressure is more than 60. So the Hill sign is positive. Respiratory rate is 16 per minute. Abdominothoracic type. SP saturation is 98% in room air. Temperature 98 degree Fahrenheit. JVP not elevated, sir. Peripheral signs of AR, Landolfi sign, D. Musset sign, Corrigan sign, collapsing pulse, locomotor brachii, Trop sign, Durosis sign and murmur, Hill sign present, sir. There is no lighthouse sign, no Becker sign, no Mullis, no Pinkies, no Rosenbach sign, no Gerhardt sign, sir.
So what does it say? What is there is peripheral signs of AR. What is the significance?
There is a wide pulse pressure. It signifies there is a wide pulse pressure, sir.
Is it severe or mild?
Sir?
Susmita,
Yes, sir.
peripheral signs, what does it indicate?
Sir, there is a wide pulse pressure, sir.
Okay.
Which indicates AR, sir.
I know.
Severity of
severity.
AR. Severity of AR, sir.
Okay.
Coming to...
Can we have the signs masked in severe AR? Can you have the signs masked in severe AR? When you will get the masked signs? All the signs will be absent.
Severe AR, there will be prominent of peripheral signs, sir.
Severe AR, which when you will get absence of all these signs despite severe AR.
In combination with AS,
okay,
there will be masking of these signs. Sir.
What is the reason for these signs? You said
due to diastolic runoff in.
Okay, that's wide pulse pressure. Either systolic BP should be high or diastolic BP should be low. The reason for reduced systolic BP or increased diastolic BP, the signs will be absent.
Yes,
what are the conditions?
AS associated HOCM.
Okay, that will reduce the systolic BP, so the signs will be less masked. When
Yes,
will you get a increased diastolic BP?
Is diastolic.
Peripheral resistance is increased as a compensatory mechanism in which condition? AR with LV
AR
dysfunction.
Okay, sir.
LV failure, due to sympathetic activity, or diastolic BP will rise.
Sure.
So
Rise.
pulse pressure will narrow. The signs may get masked.
Okay,
Okay.
sir.
Proceed, doctor.
Cardiovascular system examination, inspection. Chest wall is bilaterally symmetrical. Trachea appears to be in midline. No precordial bulge. Apical impulse seen in the left sixth intercostal space, 2 centimeter lateral to the midclavicular line. Visible pulsations seen over bilateral supraclavicular area. Visible parasternal pulsations seen. No epigastric pulsations. No dilated veins or sinus over the chest wall. No kyphosis. No scoliosis. No chest wall deformities. Palpation. Trachea is in midline. Apex bit felt in the left sixth intercostal space, 2 centimeter lateral to the midclavicular line. Hyperdynamic in character. Left parasternal heave present, grade 2, which is late systolic. Diastolic thrill felt over the left third intercostal space. No epigastric pulsations. No palpable sounds. Percussion. Right heart border corresponds to the right sternal border. Left heart border corresponds to apical impulse. Liver dullness in right fifth intercostal space. Dullness in left second intercostal space up to 2 centimeter from left sternal border. Auscultation. Mitral area. First and second heart sound heard. Soft S1 present. A high pitched soft blowing pansystolic murmur of grade 3/6 radiating to the axilla, best heard with diaphragm of stethoscope with patient in left lateral position and breath held in expiration, which is accentuated by hand grip. No S3, S4, no added sounds. Tricuspid area, first and second heart sounds heard. First heart sound is soft, no other added sounds, no murmurs. Aortic area, first and second heart sounds heard. Second heart sound soft, high-pitched blowing, decrescendo, early diastolic murmur of grade 3/4, best heard with patient in leaning forward position with diaphragm of stethoscope and breath held in expiration. No added sounds. Second aortic area, first and second heart sounds heard. Second heart sound is soft, high-pitched blowing decrescendo, early diastolic murmur of grade 4, best heard with patient in leaning forward position with diaphragm of the stethoscope and breath held in expiration. No added sounds. Pulmonary area, first and second heart sounds heard. Second heart sound is soft, normal splitting of second heart sound present, no added sounds or murmurs. Other system examination, respiratory system, bilateral normal vesicular breath sounds heard, no added sounds. Abdomen soft, no organomegaly. Central nervous system, no focal neurological deficits. Diagnosis, here is the patient. Here's a case of acquired valvular heart disease of rheumatic etiology involving both mitral and aortic valve in the form of severe aortic regurgitation with moderate mitral regurgitation with cardiac failure without evidence of pulmonary hypertension, active rheumatic activity, and infective endocarditis. Patient is in NIHA class 3 and in sinus rhythm.
Doctor, go to auscultation, mitral area. Okay, if there is S3, what's the inference?
If
In your case.
in failure, sir, in LV failure, in LV systolic dysfunction, there will be LV-S3, sir.
Can you get S3 in severe MR?
No, sir.
No, you can get S3 in severe MR. If it's a chronic MR, you will get S3. Can you get S4?
S4 is absent in chronic MR, sir. In acute MR, S4.
Good.
It
If you hear about S4, then it must mean acute MR.
Acute
If there
MR.
is S3, it is chronic MR. Both the things can you hear despite without any LV dysfunction. Even without LV dysfunction, you can hear S3 or S4 depending upon the chronicity of the MR.
Okay, sir.
What are the added sounds you can expect in MR?
Sir, in added sounds.
Mitral area, what added sounds you will get?
Sir,
Only clicks.
opening
snap or clicks?
clicks, sir.
MR not clicks. Opening snap, if you are thinking about MS, then it is
MS,
opening snap.
opening snap.
How will you differentiate flow MDM or can you get flow MDM in this case, MR, severe MR?
Yes, sir. Yes, sir.
How do you differentiate that MDM from MS?
There is no opening snap in flow MDM, and there is no pre-systolic accentuation in flow MDM, sir.
Okay. If it is secondary to MEP, you can hear clicks.
Yes, sir. Mid-systolic clicks may be here in MVP, sir.
Go to the aortic area. Go to the second aortic area. Hello?
Yes, sir.
Tell about the murmur in the aortic area.
So it's a high-pitched blowing, decrescendo, early diastolic murmur of grade 3/4. Best heard with patient in leaning forward position with diaphragm of the stethoscope and breath held in expiration, sir.
What is the murmur is due to?
Murmur is due to
Probably.
probably AR, sir.
Can it be a PR murmur? Pulmonary regurgitation murmur.
It's a Graham Still murmur. It may be, but there is no wide pulse pressure. There is no shift of cardiac apex, sir, in pulmonary regurgitation murmur.
Tell about the auscultation, based on the auscultation alone. Which area you are hearing this murmur? Where will you get PR murmur?
PR murmur is heard in left second intercostal space, sir.
Okay.
Which increased on inspiration, sir.
Good. So but here the murmur is increasing on
expiration and leaning forward.
Leaning forward. Okay.
What are
the other auscultative findings of pulmonary hypertension? That may be associated.
It's a palpable P2.
Auscultative.
It's a loud P2, sir. And there is a ESM in the pulmonary area. Or maybe early diastolic murmur in pulmonary area, sir. There are also tricuspid region. There will be PSM, sir.
Secondary to TR.
Yes, sir.
If there is a MDM, can I get a MDM murmur in the tricuspid area in severe pulmonary hypertension? Can you get a MDM murmur in the tricuspid area in severe pulmonary hypertension? Secondary to PR. If it is so, what it is called?
Secondary to PR?
MDM in the tricuspid area. Can you get a MDM in the mitral area secondary to severe AR?
Yes, sir.
What is it called?
Austin Flynn murmur.
Similarly, if you get a MDM in the tricuspid area on the right side, it's called right-sided Austin Flynn. Okay.
Okay, sir.
What are the other auscultative findings?
Sir?
That's more சொல்லுங்க.
You get also in TR flow MDM in right side.
Okay, sir.
Regurgitation.
Okay, sir.
Okay. Okay.
What I mentioned about second aortic area, no? What's the other name?
Erbs area, sir.
Any other name?
Neo-aortic area, Erbs area, or
Okay.
second aortic area, sir.
What is the auscultative finding of acute AR?
Acute AR. There will be early diastolic in acute AR. Early diastolic murmurs, sir, in new aortic area, which is
What about S2?
S2 is soft S2, sir.
Okay.
Why
What
it is
about
soft,
acute?
doctor? AR?
The S2 intensity of the S2 is depends on the aortic and diastolic pressure, sir. Here, due to diastolic runoff, there is a very low diastolic BP, so there is a soft S2 in AR, sir.
Why do you get a loud beat on pulmonary hypertension?
Due to prolonged pulmonary hangout interval, sir.
No. Same reason. Due to the increased pulmonary pressure, end-diastolic pressure. What you told, no, same thing applies for the pulmonary also. Both the great arteries determine the intensity of the second heart based on the diastolic pressure.
Diastolic pressure.
Diastolic pressure is elevated in pulmonary hypertension, so only the P2 is low. Similarly, the diastolic pressure is very low in AR, so only A2 is soft.
Okay, sir.
What is the oscillatory finding of acute MR?
Oscillatory acute MR, there is a early systolic murmur, sir.
Okay.
What are the other conditions you will get early systolic murmur?
Early systolic, severe TR, severe MR, then large VSD with the pulmonary hypertension and the small muscular VSD, there will be early systolic murmurs.
Good.
Okay.
Proceed, doctor.
Diagnosis, it's a case of acquired valvular heart disease of rheumatic etiology involving both mitral and aortic valve in the form of severe aortic regurgitation with moderate mitral regurgitation with cardiac failure without evidence of pulmonary hypertension, active rheumatic activity and infective endocarditis. Patient is in NIHA class 3 and is in sinus rhythm, sir. I would like to proceed with the basic routine investigation with like CBC, RFT, LFT, CRP, ESR. And ECG echo, sir. Here is the ECG of that patient showing speed of the paper is 25 mm per second. Standardization 10 mm is equal to 1 millivolt. Normal sinus rhythm. Heart rate is 65 per minute. Axis is 30 degree, which is normal. P wave normal width and amplitude. PR interval is constant. S wave in V1 and R wave in V5 is more than 35 mm. No secondary ST-T wave changes. Q waves in V5, V6. It's due to body effect. Impression, LVH due to volume overload, sir. Chest X-ray. No rotation, good penetration, taken in inspiration. Bony structures and soft tissues are normal. Lung fields are normal. Prominent bronchovascular markings in bilateral lung fields, trachea in midline, cardiomegaly present, LV enlargement present, cardiophrenic and claustrophrenic angle appears normal, sir.
How will you say it is LV or RV apex?
If it is RV apex, it is shifted only to the lateral. No, sir. If it is RV apex, it is rounded and uplifted, which is in acute angle. But if it is due to LV apex, it is shifted down and out and rotated laterally, sir. The angle is obtuse angle, sir.
What are the chambers likely to get enlarged in your case?
Sir, LA enlargement and LV enlargement, sir.
Is there LA enlargement in the X-ray?
No, there is no LA enlargement, sir. Only LV enlargement is there.
What are the possible X-ray findings of LA enlargement?
Sir, double shadow sign and splaying of carina.
What happens to the left heart border?
Left heart border is shifted laterally down and out due to LV enlargement.
No, doctor. Above the LV, you will get a straightening of left heart border, no?
Yes, sir.
That is secondary to?
LA enlargement.
Arterial appendage enlargement, secondary to LA enlargement.
Okay, sir.
What are the X-ray signs of right atrial enlargement?
Right atrial enlargement. Right atrial enlargement, there will be occupying three spaces, three intercostal spaces, and more than 5.5 centimeter from the midline, sir. RE enlargement occupies more than 50% of the left hemithorax, and Euler's ratio is more than 0.8.
Go to the ECG. What is the normal PR interval in your case? PR interval is constant.
Yes, sir.
If PR is enlarged, PR is increased, what's the probability? In your case, if PR is prolonged, what are the probabilities?
In Epstein's anomaly, it is prolonged, sir.
No. In the case of your case, I am talking not about. I am not talking about Epstein. I am talking about your case. A chronic MRAR.
Yes, sir. Any heart blocks?
What is the reason for heart block?
If there is any secondary causes like CAD, it may lead to heart.
Patient is on treatment. Any drug that prolongs the PR interval in your case that you have prescribed?
It's a beta blockers.
Or
Digoxin.
Digoxin. Patient is having fever, arthritis in your case.
Yes, sir.
What is the relevance of prolonged PR? Heart block.
Okay, sir.
Acute rheumatic fever.
Okay,
Prolonged PR interval is
a minor criteria. Yes, sir.
Okay. So whenever a patient with RHD comes with prolonged PR interval, you have to think of
Suspect acute rheumatic fevers.
it may be a sign of carditis or it may be a drug effect.
Okay, sir.
Okay. Proceed.
Echo finding, AML and PML are thickened. PML mobility is restricted. AML dooming present. Mitral regurgitant velocity 44 meter per second. LV dilated, no regional wall motion abnormality. Tricuspid annular plane systolic excursion is 19 mm and tricuspid regurgitant pressure gradient is 25 mm. There is no pulmonary hypertension, no RV dysfunction, and left ventricular internal diameter is 59. Ejection fraction is 66%. Severe MR, mild MS, which is central jet. Tricuspid aortic valve. Aortic valve gradient is 28 mm Hg. Aortic annulus is 29 mm. AR pressure 250 milliseconds. Pressure half time is 250 milliseconds. Is a pressure half time 250 milliseconds. There is no aortic stenosis and severe AR. No pulmonary embolism or clots. Pericardial effusion or clots.
Can I get a clot in this in your case?
No, sir.
Why?
The palpitations are regular, sir. If it is irregular due to ineffective atrial contraction, there may be a clot formation, sir.
Look, what is the prerequisite for clot formation? Stasis.
Stasis. Okay, sir.
Stasis. Only in obstructive lesion or LV dysfunction, there will be stasis.
Clot formation.
The
okay.
case is not having any obstruction or there is no LV dysfunction. So the blood is flowing freely. So there is unlikely a possibility of developing
Clot
clots.
Coming to the treatment, the definitive treatment is a double valve replacement, medical management, fluid and salt restriction, antibiotics like penicillin 250 mg BD, tablet furosemide and spironolactone enalapril for anti-failure measures, and tablet ISDN for chest pain. So, definitive treatment is double valve replacement. So.
If the patient is having severe pulmonary hypertension,
Yes, sir.
Hypertension, irreversible.
Sir?
severe pulmonary hypertension with the severe TR in this case, what will you do? You have to repair the tricuspid valve also.
Okay, sir.
How long will you give penicillin?
Sir, penicillin as a tertiary prophylaxis in patient with no carditis, we have to give for 5 years or up to 18 years of age, whichever is longer. According to WHO guidelines, patient with carditis, we have to give for 10 years or 25 years, whichever is longer. Patient with severe carditis and the patient with prosthetic valve, we have to give lifelong penicillin, sir. According to
Not severe.
ACC guidelines, up to 40 years we have to give, sir.
What penicillin?
Sir,
Oral penicillin is penicillin B or penicillin G? It's penicillin B. Okay.
B, sir.
What is the dose of peridure? Benzathine penicillin?
1.2 million units, sir. If less than 27 years, half the dose, 6 lakhs units.
27 years.
27 kgs, sir.
Kgs, okay. Why do you give enalapril?
So to prevent cardiac remodeling,
How do enalapril acts? What is the mechanism of action?
enalapril is a AC inhibitor, sir. It
Okay.
inhibits the AC enzymes, angiotensin converting enzymes.
What does it do on the vessels? It's a
It causes
vasodilator.
dilation.
Afterload or preload?
It reduces both preload and
Vasodilation.
afterload. It
Okay,
reduces both the preload and afterload, which is important in your case. You have to reduce
reducing the
preload and
afterload. Reducing the afterload is important.
both preload and afterload should be reduced.
Okay, sir.
Okay. Which is the most yours is a case of double wall lesion, no?
Yes, sir.
Double wall disease. Among the double wall lesions, which is the most common lesion?
MS and MR, sir. MS with MR.
MS and AR is the most common combination. Which is
Okay,
the
sir.
most dreaded combination?
MR with AS, sir.
Good. Okay. Will nitrates help in this case?
Yes, sir. Nitrates, reducing the afterload in AR, sir.
Good. Okay, very good. If there is angina, what are the probability? This in your case.
Due to reduced blood flow to the coronaries, sir. Due to diastolic runoff, there is reduced blood flow to the coronaries, and also due to Venturi effect by the regurgitant jet, causing coronary stealing, sir. Therefore, the patient may experience pain, sir.
Okay.
Increased
What
demand.
is nocturnal angina?
In the night, there is a decreased sympathetic tone. There is a bradycardia. Bradycardia increases the bradycardia also increases the aortic regurgitation. Therefore, pain increased on night, sir. Due to decreased sympathetic activity, decreased coronary flow, sir.
Diastole is prolonged in night.
Okay.
Sir,
Diastole is prolonged. Night.
diastole is prolonged. Sir.
Okay.
Patient is having angina. What are other probabilities in your case?
It may be due to HOCM, sir, or it may be secondary to
It's a
any
case of-
coronary artery disease, HOCM.
Why? Is it possible in your case CAD?
Yes, sir. Mitral
What is it?
regurgitation, papillary muscle rupture, and chorda.
No, doctor. Your case is a smoker, no?
Yes, sir.
42 years smoker. There are all the probability of having a associated CAD.
Okay, sir.
First, you have to do angio. You have to rule out coronary artery disease,
Yes.
and then you have to do double valve replacement. First, you
Okay,
have to rule out coronary artery disease before
Okay,
doing
sir.
valve repair.
Okay, sir.
Any questions, sir?
Good, doctor. You presented nice. Anything else? Rajkumar?
Nothing. Can we wind up? Saravanan, sir?
Yes, sir. I think Sushmita answered very well all the questions, almost every questions, and we also discussed about different aspects of the clinical as well as investigation. Thank you, sir, for being active participation in this discussion. And I'd like to thank Dr. Suresh Khanna sir for being with us for the last 12 weeks. I think this is the last week of the presentation by Salem Medical College. Thank every one of you for active participation. Special thanks to all the faculties of the Department of Medicine and Specialties, and special thanks to Suresh Khanna sir for being actually involved in this, organizing this work and participating in this virtual program. And thank every one of you, and thank you. Good night to all of you.
Thank you,
Thank you,
sir.
sir.
Good night, sir.
Thank you, doctor. All the best. Thank you.